Perfect. Well, welcome everyone to the main meeting for the Rural HPV Vaccination Learning Community. So on behalf of the American Cancer Society and the National HPV Vaccination Roundtable, I want to thank you for taking time out of your busy schedules to join us today, whether that's live or via recording in the future. We will be offering live CME and CNE credits for today's session. So today we'll be covering the capacity building stages of the quality improvement framework. For those that joined us last year, we took many of these topics and talked in depth month by month, but today will be an overview of these elements of the framework. So for those that are new to Learning Community, I'm going to direct you to our 2024 session recordings to get a more in-depth look at each topic that we're going to cover today. I do want to note that this program is supported by a grant from the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services. If you want to go to the next slide. So can you go back one? Sorry. So I'm Ashley Locke, HPV Program Manager here at the American Cancer Society. I work on our disparities work. I have the honor of talking to you first, but I am a part of a much larger team that encompasses many colleagues from both the American Cancer Society and the National HPV Vaccination Roundtable who work on increasing HPV vaccinations every day. If you want to go to the next one. So as always, we try to do a icebreaker with each of you. So today, because we are coming into that summer season, if you haven't done so already, please add your name, organization, and what you'll be bringing to our summer barbecue into the chat. And I look forward to reading some of them off here. I'm going to check and see if we've gotten any yet. Oh, Kat's going to bring bug spray. Now that right there is very important. Barbecue baked beans, that's a great one. Watermelon and s'mores. We have done a lot of s'mores here in my house. So I definitely love that. Potato salad, all the dips, street corn, sounds amazing. Pickles, my daughter would love you for that one. Steak tips, rum cake, burgers and more potato salad, some steak, watermelon, cucumber sandwiches, chips, and pickle salsa. That is an interesting one. I've never tried that. Burgers, chips, lots of great things in our summer barbecue. So feel free to keep adding them into the chat. And so those of you that just joined, we're just doing a quick icebreaker, name, organization, and what you'll be bringing to the summer barbecue. If you want to go to the next slide. So we always have a packed agenda, and today is no different. So in just in a minute, we're going to quickly review a few items that were shared from our April session, and then we're going to hear from Emily Hoffman, a rural cervical cancer survivor. After that, you'll hear from two of my colleagues, Dr. Jennifer Isher-Witt and Kim Hale, who will talk through the capacity building stages of a quality improvement project. I do want to share a few quick reminders with each of you. So our rural HPV vaccination learning community sessions are recorded and posted to a public-facing website. So for any reason you would like to not have your image shown, please turn off your camera. Additionally, this session is certified to provide live CME and CNE credits. So we've added a link to the chat detailing out our CME information for today's session. I do want to note that none of our planners or speakers for today's session have anything to disclose. And then, as always, we ask participants to stay muted until our question and answer discussion. However, our Zoom chat is open for questions and support, so feel free to message us. You want to go to the next slide. So for today's session, we are going to be focused on the following learning objective, which is reviewing QI tools like aim statements, process mapping, gap analysis to identify areas to improve HPV vaccination rates in organizations. Next slide. So before I get into the content for today's session, I do just want to do a quick knowledge check with you. This is particular from our April session, so please let us know which of the following is a recommended strategy to reduce missed opportunities for HPV vaccination. Give you all a few minutes to go ahead and take this poll. Right, looks like we have about 65% participation. Would love to get to 80%. 70% participation. 71. Just a couple more. Feel free if you
The
can.
poll got ended, so
Oh,
I
that's
don't know
okay.
the result.
No worries. Thank you so much. If you want to go to the next slide. All right, perfect. So I'm going to go ahead and just share a little bit more on our April session. This is going to be a quick review of some of the info that was shared by Dr. Grace Ryan. So if you want to go to the next slide. So Dr. Grace Ryan did take us through her research on rural communities prioritizing the HPV vaccine and missed opportunities. Her research found that during the pandemic, HPV vaccination was often deprioritized, which led to delays in vaccination. This really underscores the need for targeted interventions to not only resume, but enhance HPV vaccination programs. So some of the tried and true interventions that she talked about that work in rural communities include system-based interventions, so standing orders and provider reminders, and then also thinking through community demand for HPV vaccination would be a client reminder recall. And we're going to talk more in depth about HPV vaccination evidence-based interventions next month, so stay tuned for that. If you want to go to the next slide. So for missed opportunities, Dr. Ryan defined them as visits at which eligible children over the age of 9 could be vaccinated against HPV but did not. And these included in this definition are well child visits, sick visits, and other immunization visits. So what her research found is there's not much difference when it comes to missed opportunities amongst geography. So looking at that urban and rural divide. Most missed opportunities occur prior to initiating the series at ages 9 and 10. Rural adolescents have slightly fewer missed opportunities, and some strategies she shared to reduce missed opportunities would be to really focus on ages 9 to 10, making some changes to EMR notification, parent reminders, including maybe birthday campaigns, and internal data review, including audit and feedback. All right, if you want to go to the next slide. So it's time to hear from our cancer survivor, Emily Hoffman. She is an 11-year cancer survivor who was diagnosed with stage 2B cervical cancer at age 30. Emily is a volunteer ambassador with Survivor, and we are going to include Emily's bio and email address in the chat. So go ahead and take it away, Emily.
Hi, everyone. I'm Emily Hoffman. I am an 11-year cervical cancer survivor, and I am from Central Iowa. Next slide. Just to kind of paint the picture of my life before cancer, I was diagnosed at age 30, and up until then, I was really very healthy and uh, never really I went to the doctor for my annual exams, but had no symptoms of before going in 2013 to my PCP. I was active outdoors, a lot of camping, hiking, fishing, in a relationship. My boyfriend had just moved in with me about 4 months prior to my diagnosis, and I was about 6 years into my first my full-time career out of college in agriculture, field research, and was enjoying life. Spoiler alert, after cancer, pretty much all of that changed. Still active outdoors, but more limited on what I can do, and definitely not as much stamina to do it. The relationship ended after treatment ended, and so I've been single since cancer. And career-wise, because of my side effects, which I'll get into in a little more in a few, I was unable to like kind of physically keep up with my job in the field, and so I ended up quitting my job and got a desk job for several years to kind of just focus on my physical health. And But then ended up having a complete career change and got into Found Cancer Registry through my advocacy work and went back to school for that. And so just for the last 2 years now, I've been a cancer registrar and I love it. So totally would not have ended up happening without cancer. Next slide. May 7th, 2013 is the day I was told I had cancer. I remember going to my PCP a few days prior to this date and her doing my annual exam, and I still sort of remember my PCP saying, "Your cervix looks different this year," and just not like really understanding, the severity or gravity of that statement at the time, and just what that would mean for me. My treatment ended up being just chemo and radiation, both external and internal brachytherapy, no surgery. Um, I really got through treatment just fine. It was a few months after treatment ended that a lot of my side effects started. Side effects for me were caused by my radiation treatment. So a lot of radiation enteritis and colitis is what I ended up being diagnosed with. But having a lot of GI issues with basically I was throwing up everything I ate. If I did keep food down, it created like a lot of intestinal cramping that once it started, it would last for literally 12 hours straight. It would, and I knew as soon as the cramp started, like I'd be in bed for the next 12 hours because it was so painful and I'd be throwing up for the first few hours of it. But just imagine that your intestines are like just squeezing really tight. And then they relax for literally like 2 to 3 minutes and then they repeat and do it again. And that's it for the next 12 hours. And it's so painful. And like I couldn't walk upright and like I missed a lot of work and it was just hard to function, and obviously I was losing a lot of weight and didn't have good nutrition and all of that. I spent the next 4 years here locally around Des Moines, just being bounced around locally with different specialists, trying to manage my symptoms. Nobody knew how to manage radiation enteritis, and so I really got nowhere. At about 4 years in, my insurance changed, so I got to Mayo and spent another about 4 years managing my symptoms different ways, but nothing really worked long term. Hyperbaric oxygen, I've done twice, and that actually did work pretty well for the short term, but like I said, never long term. So about 8 years of all this pain and suffering with my digestive issues. We finally got to my last resort. I was at my lowest weight. I was under 100 pounds and still working full time and, now back in school for registry and just trying to function. And so my last resort was TPN. And so what is TPN? Next slide. TPN is total parenteral nutrition. It means I get all of my nutrition and hydration now through a vein in my chest. I have a catheter. So literally like a IV bag of liquid formula and tubing and a pump and a backpack, and that all runs for 12 hours a day, every day. So I run it overnight. And just to I wanted to kind of show like what that looks like supply wise. So like on the left side of my slide, you can see like in the evening when I get hooked up, you can see the bag of formula there is kind of in the center of the slide, and all the supplies it takes to get me connected with my tubing and pump and backpack. And then in the morning, to all the supplies needed to disconnect and go about my day. I do say that TPN is a lot of work, but it is totally worth it. I've gained back 20 pounds, and now I can maintain my weight. I don't have to eat food, so therefore I feel good. I'm not throwing up on a regular basis, and it's just been very life-changing to now be on TPN. I'm still on it today and there's no plans to stop at this point. And then I just kind of wanted to help show week one when I started back in 2022, like just how I was 95 pounds and very thin. And within 3 months, I gained 15 pounds, and have since gained a little more from that, and I'm able to maintain it. And so it's just been really nice. Next slide. Although it's been rather extreme. Um, with cancer, I never really, set out to share my story or be an advocate at all. I really just, after cancer ended, I really just wanted some support, and I didn't know any other cancer survivors really going through treatment or even after treatment, and until about 2 years after treatment ended is when I found Survivor, the organization, online. And then the next year at 3 years, finally met some survivors. And that's when I found my community, and just getting that support obviously was very important. And then through Survivor School, learning about HPV, and then the HPV vaccine. And that really helped me realize that, wow, I have a responsibility to share my story now, because this vaccine can prevent my cancer, right? And so, the advocacy didn't come easy for me. And I think even in those first couple of years, like I was doing some videos and speaking at a few conferences, but I was very uncomfortable. And I think just even in the last couple of years, I feel like I'm really growing as an advocate, and finally I'm more confident and more comfortable sharing my story, because it's taken a long time. And so I just want like people to know it's not always easy, and not everybody jumps right into it. Next slide. Um, so yes, at Survivor School, once I learned about the vaccine, and just it was just that aha moment that I had of, this is cancer prevention. And like I might get a little teary, but it means my cancer could have been prevented, and all this pain and sickness that I just went through means like someone else shouldn't have to go through that. And ultimately it means we could end cervical cancer, right? So obviously it's very personal to me because of all of my side effects and issues. Um, real quickly, I'm not on social media either. And so to be an advocate is sometimes you have to think creatively of like ways to advocate outside of the computer. And so one of my favorite ways, and a way that lots of people know me by, is my button story. Several years ago, the Iowa Cancer Consortium had created these buttons that say, "Ask me about the HPV vaccine," and they handed them out at their conference. And I took my button and I put it on my purse that day. And I thought that was going to be an awesome way to like strike up conversations with people. And literally the next day I went to REI, and as I'm checking out, my cashier literally asked me about the vaccine because she saw my button. And I was not prepared. I didn't but I stumbled my way through it. We had a good conversation for, a quick couple minutes while she checked me out. And I was just so excited that it worked, even though like I stumbled my way through it. And so then I realized, okay, if this button works, so I need to have a quick little spiel, um, to tell people in case they ask me again. And I now keep that button on my purse all the time. I've had people all the time stop and ask about it. Walgreens, the grocery store, the state fair, everywhere. And so my three little things that I try to remember that I want the people to know, because usually these conversations are really quick, right? And like in passing. And so I'm like, I always try to get in that it's cancer prevention, right? I don't need them to know anything else except that it prevents cancer. Um, it's safe and effective, and you can give it to girls and boys. And usually that, because I've had questions about the whole, boys thing. So I like to add that little fact in and see where the conversation goes from there. But yeah, I would say between the vaccine and my side effects, those are really the two things that are my why and why I share my story. Next slide. Since we're talking about living in rural areas today, I just wanted to, throw in the thinking about the impacts of living rurally on my cancer journey. And I'm sure these are all things that you've all are aware of and know about, because I think that they are relate to every cancer patient and survivor. But obviously my treatment, the hospital was 45 minutes one way. And so it's just the daily travel of it. And then there was only one gynecological oncologist at the time. So I really didn't there was no second opinion option. For my side effects once treatment ended, nobody knew what to do with me here. And so I just feel like those first 4 years were totally wasted. And so that's unfortunate. And with survivorship, of course, it's lonely, right? And I didn't find anyone for 2-3 years after my treatment ended. And even though there are events in the like Des Moines, it's hard to get to. And even if you are closer to Des Moines, there's just low attendance because the farther out people can't make it. So it's just difficult. That photo is also from my backyard, which is one of my favorite photos. So next slide. And then just, the impact our voices as me as a survivor and my fellow survivor ambassadors and everyone has, like, they all make a difference. And, at the beginning, my first video I did for Survivor in 2016, like I was all shadowed in blackface, like you couldn't see me, like a witness protection video, because I didn't want to be known as the girl with cancer and I didn't want my face out there. The next year I did a video for Iowa Public Health and their HPV campaign, and you saw my face in that one. Still really uncomfortable, but I was doing it. And then it progressed to speaking at conferences and just making partnerships and with different organizations and around Iowa. And then working at my in-between job before registry was working at the Diocese of Des Moines. And once I disclosed my cancer story to my coworkers, they ended up writing an article about me in the Catholic newspaper that goes across the state of Iowa. And so I just thought that was crazy. We're talking about my cervix and the Catholic Church, and that's awesome. So, and the HPV vaccine. So, and then last year, I had an article in the Iowa Cancer Report to highlight cancer registry and my cancer story. And I just love at the bottom of this slide how, we also do proclamations for Cervical Cancer Awareness Month every January in the state of Iowa here. And like our first year in 2018 or 19 that was, and look, it was just 3 of us. And then a few years later, look how many more partners and support we have now with all of our advocacy work and how it's growing, which is awesome. Next slide. These are ways to connect with Survivor, the organization near and dear to my heart that has helped me with support and advocacy growth. And next slide is just my contact info, which, as I've said, I'm not on social media, but I do have email. So you can find me there.
Emily, thank you so much for sharing your story and for being so brave. You have such an incredible story to share, and I absolutely love the button story.
Good.
I think it's such a powerful, intervention, and it's such a great way to start conversations, and you're so creative, because you don't have social media, so you have to have those in-person conversations. So you got a lot of love in the chat, and I highly encourage you to look at that. We will be having a Q&A later on in the session. So if you have any questions for Emily, feel free to type them into the chat and we can take them during that time. But thank you again, Emily, for sharing your story. You really are a true testament to what it means to be brave and resilient. So I am now going to just briefly introduce our next speaker, which is Dr. Jennifer Isher-Witt, known as Jen. Jen has been with the American Cancer Society since 2009 as the Director of Data and Evaluation on the Implementation Science team. We are going to include Jen's full bio into the chat as well as a way to connect with her.
All right, thank you so much, Ashley, and thank you, Emily. Yeah, I'm going to talk. You can go on to the next slide, please. I'll be talking a little bit more about data and the quality improvement framework, and specifically the capacity building stages, so that we can ensure that health systems, especially in rural areas, have the ability to distribute and increase their HPV vaccination rates. You can see here in yellow, these are the stages of the capacity building phase. We've got strengthening systems, infrastructure, and human resources, all to improve vaccination delivery, uptake, and sustainability. So this is all the pre-work, right? This is what we're doing before we identify the interventions to make sustainable change. So in the capacity building stage, it's really where you'll be working to uncover where gaps are and how to identify opportunities that exist. And as you can see there, collect data is the second step. And that's what I'm going to be really focusing on. So on the next slide, we're going to talk a little bit about using data. So and why we use it. So after forming a team, which Kim Hale will be talking about a little bit more after me, we need to know what the story is, right? So that's one of the reasons that we look at our data. Data tell us what the story is. They help us understand how a system is doing with vaccination and whether it's necessary to focus efforts and resources on initiation or completion or a certain age range. Some clinics might be doing really well and not need to go through the entire quality improvement framework or intervention process, and really just sort of tailor a certain point. So when we look at our data and it tells us the story, we're better able to assess where we need to focus our efforts. And that helps us provide this concrete guidance, right, or concrete evidence to guide our decisions. And once we're able to make those decisions, we are then able to use data to evaluate the impact of those decisions and those interventions. And we're not just looking at numbers, right? We're sharing a narrative that's going to highlight successes and challenges as well. So we'll get a sense of our rates, what worked, what didn't work, and acknowledge all of the hard work and effort that goes into a QI project. Especially for HPV vaccination. And I think being able to share through this narrative, share in a narrative and through a storytelling approach, it can be really powerful in engaging stakeholders and building support for initiatives. So as we move forward and we dig even deeper into the weeds of how to measure rates, please remember that data is not just analysis. It's not just numbers. It's a whole host of things. It's quantitative, it's qualitative. It involves lots of stories, and it's all equally impactful. So on the next slide, let's go ahead and talk. We're going to get a little bit weedy here. So this is a visual that will hopefully help sort of demonstrate one of the ways that we measure HPV initiation rates here in our QI projects. So let's take a moment to understand the key components here. First we'll look at the numerator. That is the smallest sort of teal subset. That represents the number of adolescents aged 9 to 13 who have received at least one dose of the HPV vaccine. And so this is crucial because it really gives us a clear picture of how many young individuals are starting their vaccination journey. And as you can see from this image, that is the subset that we've broken down, starting from that larger total patient population, right? So if I could backtrack a second, so we've got our total patient population, and then a subset within that total patient population is our denominator. That's going to be our number of adolescents who have had an active medical visit in the last year. And then from that group, that is where we're going to see how many of those have started the HPV series. And we put our numerator over our denominator and divide, and that is how we get our initiation rate. Okay, let's go on to the next slide. Okay, and you heard a little earlier from Ashley as she recapped Dr. Grace Ryan's talk last month. Another way that we can determine progress and get a sense of where a clinic might be at is by measuring missed opportunities. So I won't go into too much detail since Ashley did a great job recapping it. But essentially, we are trying to figure out what is the missed opportunity rate. So how many visits, what percentage of visits where there are eligible 9 to 13-year-olds who are due for visits or due for doses are not receiving them. So the slight difference here between the initiation rates versus missed opportunities is that for this particular denominator, we're looking at total medical visits. And sometimes it's the last 30 days. It could be a different time frame. But we're looking at medical visits instead of patients. And we're looking at how many were due and then how many were not given as that numerator there. And that's how we can also calculate an overall missed opportunities rate. And it's also interesting, some clinics will go ahead and take this one step further, and they'll break down these rates by the type of visit. So is it a well visit? Is it a sick visit? Is it a nurse visit? And sometimes that can give a better sense depending on what the clinic's workflow is. So maybe the clinic is in, maybe it's not standard protocol to offer vaccines at sick visits. So you'd expect maybe that missed opportunities rate to be really high, but that's not really where you want to be targeting. You want to be targeting maybe those well visits. So it could be beneficial to further break that down. And finally, on this last slide here, thank you. We have a lot of resources, and there are lots of resources out there or data sources where vaccination data can be found, and different types that you can draw from depending on what kind of information you're looking for. So on this slide here are just a few examples of some of the available, publicly available data. So there's cancer statistics, immunization data, whether that's from your own state's registry. There's health plan, there's payer and claims data, the ACS HPV QI cohort map. That is a historical capture of the last 8 or so years of the quality improvement projects that ACS has helped facilitate. There's additional supporting sources. And then most recently, the cancer prevention and early detection facts and figures that came out recently is a great resource to get information, statistics about vaccination data, to get a better sense of where we are nationally, and some other related statistics. And what you see here on this slide is just sort of, like I said, just a sampling of some of the sources. And what you can see on the bottom of this slide, as well as in the header there, are the actual links to the document that compiles all of this information and has further details such as pros and cons of each source, and a little bit more detail about what it is and when you might want to use it. Okay. So I'm going to finish up with a poll. So Kayla, if you could please, thank you, pull up that poll. So have you reviewed or pulled baseline HPV vaccination data for your patient population within the past 12 months? And if so, what source did you use to pull your data? So we'll try to get to 80% if we can. And then Kayla, if you could share those results once we get closer to that point. All right, we've got lots of yeses, 70%. That's fantastic. Of course, we've got some folks on here not applicable to your role. Of course, we knew that would be the case. That's perfectly fine. Right, we're at about 40% participating, and about 2/3 have pulled the data. It looks like the majority of the sources have been immunization, IIS, EMR, IMA. Wonderful. Can we get just a few more folks? We're at about 50%. All right. Okay. Looks like the trends are fairly consistent here with most folks who have been able to pull, which is fantastic. Hopefully it's been insightful and helped to guide you in your next steps. And yeah, a range of sources here. All right, are you all able to see the poll at this point or not yet? Am I just talking about invisible numbers?
It looks like 52% have participated.
Not yet. Okay, you know what? Let's go ahead for the sake of time. Let's go ahead and share those results so that you all can take a quick look. Thank you. There we go. All right. Wonderful. Thank you. Thank you so much, Kayla. Thank you all for participating. And I am going to go ahead and turn it over to my colleague, Kim Hale. Kim is an associate director for state partnerships at the American Cancer Society. She has a long history building quality improvement projects with healthcare partners. Kim's full bio and a way to connect with her will also be added in the chat. So please take it away, Kim.
Thank you, Jen, and thank you, Emily, for sharing your story. That was so powerful. So we're going to jump right in. So once you pull your HPV data, and it does show that you need to focus resources and efforts to prioritize HPV vaccination, it's time to build a team because quality improvement works best as a team sport and not an individual sport. So let's take a moment to consider what makes a team truly successful. First, it's crucial that teams incorporate diverse points of view. When we bring together different perspectives, we open the door to innovative solutions and better decision making. Next, including everyone who is relevant and invested is essential. This ensures that all voices are heard and that we're not overlooking any critical insights that could help us achieve our goals. Lastly, utilizing champions to overcome barriers is key. These are individuals who can inspire, motivate the team, helping to maintain momentum through challenges. So, as we think about these principles, let's keep in mind the importance of regularly scheduled meetings to work through the quality improvement framework together. I would also like to share some pro tips throughout my presentation that includes my personal lessons learned and best practices. And the first one is people support what they help create. Another reason why it's important to use teams. Now we're going to look at key members and what key members to consider for our HPV projects. It's essential to understand the roles of each individual and what they play on the team's success. These roles and titles may look different depending upon your organization type, for example, an FQHC or a county health department. First, we have a sponsor or a champion. This could be your director of nursing, your medical director, or a pediatrician. They're the ones who provide the vision and support for our initiatives. Next, we need an owner. This is typically the quality improvement or the PI lead, along with an RN or MA who will drive the project forward. Then we have our tech expert. This person helps us navigate the technology landscape, whether it's through health information technology, informatics, or registry expertise. It's also crucial to include a subject matter expert. If you don't have a pediatrician champion or a pediatric RN or MA as your sponsor, try to identify one to join regular meetings as your subject matter expert. They bring invaluable insights to your efforts. And we cannot forget about the customer. This includes patients, parents, health department representatives, survivors, and community health workers. Their perspectives are vital to ensure our initiatives are truly effective. Lastly, think about including other team members from different areas, such as front desk, medical education, outreach, dental teams, and even a residency team representative. Now, I want to hear from you. Share in the chat who's missing from this list. Your input can help us refine our approach and make our team even stronger. We may have done a good job listing. Your local, community-based organizations, absolutely. Patients, yes. Dental providers and staff, good one. Yes, your health plans. School nurses are a phenomenal connection. Also, PTO or PTA presidents or leaders within the schools. Health teachers, absolutely. Okay. Oh, access to care teams for sure. All right. So now we're going to go into setting an aim or a goal. You may not identify all the team members right away. In fact, many of our partners add staff members as they ramp up interventions or expand efforts from year 1 to year 2, and after you identify your core team. Now it's time to define your goal or aim. So let's focus on the importance of setting a clear intention for improvement. A well-defined aim answers the critical question, what are we trying to accomplish? It's essential that our aim is not just a vague statement, but rather uses the SMARTY structure, which stands for specific, measurable, achievable, realistic, timely, inclusive, and equitable. This structure helps us focus on the overall project or even specific components like initiation or completion, age groups, or even genders. The next slide will show us a template that we provide to participants last year, but want to make sure all participants know this is here with other AIM statement templates that are available for you to use for in-person or virtually. This template will ensure that your goal meets those SMARTY components. So let's take a moment to look at some sample AIM statements that illustrate how to set clear, measurable goals. Each of these statements are a little different. Let's look at the one in red first. By October 1st, we aim to document HPV vaccination administration or refusal in 75% of adolescent patients' charts at our pilot office using a designated EHR vaccination template. This goal is not just about numbers, it's about ensuring that we have the right data to improve our services. Additionally, let's look at the last statement in blue. We aim to increase HPV vaccine series completion among male patients between the ages of 9 to 12 from 23% to 39%, completion rate among female patients of the same age in our Porter County clinics by June 1st of 2025. As you consider these examples, think about how you can apply a similar structure to your own AIM statements. This will set a strong foundation for your action plan and help identify potential interventions to create change. A pro tip, post your AIM statement in your clinic that everyone can see. And at the top of your meeting minutes or notes or agendas, this will help everyone know what the team goal is, especially if you have new team members join or you have visitors join you, so that everybody is on the same page. As soon as you have an aim or a goal statement, it's time to shift focus to your action plan, which will help us effectively reach our goal. First, think of this as a living document. We need to revisit and adjust it often, ensuring we remain responsive to our goals and any changes in our context. Next, we must integrate quality improvement processes taken and any evidence-based interventions identified. This isn't just about following a checklist. It's about embedding these practices into our daily operation or standard operating procedure. Include key collaborators in this process. Their insights and expertise will be invaluable in refining our action plan and ensuring we address all aspects needed for success. Finally, be specific and thorough in your planning. The more detailed we are now, the smoother the execution will be later. Get those deep, detail-focused folks on the development of this tool. Remember, a well-crafted action plan is crucial in guiding us toward our aim. So let's make sure we have the right resources in place to support our efforts. And we have a wonderful template available for you in our resource roundup that we'll link in the chat for you. All right, we're going to do a poll and hear from you. So our poll is, where are you in the process of developing or implementing an AIM statement and action plan for improving your HPV vaccination rates? And we'll follow Jen's lead, and when we get to about 50% or 60%, we'll share results. So about a third of you haven't started yet, which is great, because we want to definitely work through this together, and you'll have a chance to ask questions as you're beginning the process. All right, I think we can end now and share the results. Excellent. So, like I said, 35% haven't started yet, 13% are in the process of development of the aim statement, and action plan in place being implemented, 9%. Excellent. All right. Thank you for participating. Now, we're halfway through our capacity building stage. So let's dive into our current state process mapping. A process map is essentially a diagram that visually outlines a series of events, steps, or activities involved in any given process. We have to understand what our current process is to understand what we need to improve. But before I do so, you might want to wonder, why should we even create one of these? Well, there's three key reasons. Defining and analyzing a process helps us gain clarity on how things are currently operating. Identifying variances from the norm allow us to spot where things might be going off track. Showing relationships illustrates how various steps or departments interconnect. Additionally, it helps us uncover redundancies, gaps, and any areas that might be unstable. Finally, one of the major benefits of doing a process map is that it provides a roadmap for training and onboarding new staff. By having this visual aid, we can ensure new team members understand the workflow and their role within the process. These are some examples of HPV vaccination process maps. I want to highlight that process mapping can happen both in person and virtually. We have templates for both of these that we'll link in the chat. They're designed to help you visualize your process effectively. They serve as a valuable tool to ensure that everyone is aligned and understands the steps involved. Let's remember that the purpose of these process maps is not just to create a diagram and have something fun and cool, but to enhance our understanding of how things flow within our organization. They provide clarity, they clarify the current state and help identify any areas that need adjusting. Collaboration, they encourage collaboration across departments by illustrating relationships between these steps. And it's a training roadmap. Once again, they act as a great way to ensure consistency in operating procedures. So as you consider these templates, think about how they can support your efforts in creating a more efficient workflow within your team. All right, another poll. How familiar are you with your clinic's current state process map for HPV vaccination? All right, so we've got about 22% not familiar, not aware of a process map in place, very familiar, about 5%, somewhat familiar, 10%, 10%. I'm not sure if we have a process map. That's great, because now you'll have the tools to be able to provide that with your clinic. Okay, we're almost at 60%. We can end the poll and share results. Very good. So I think this block of instruction is really great for this group and where you are in your process. Okay, so now beyond mapping out your process, it's really important to do additional analysis to determine the underlying reasons for a specific problem. By doing so, it'll help to narrow down even more where there are opportunities to increase vaccinations within your organization. We don't want you throwing noodles or spaghetti against the wall, but identify interventions that are going to fit, that they're going to make a positive change within your organization or clinic. You may have heard both gap analysis and root cause analysis, which is RCA for short. They are not one and the same, so quickly let's dive into the differences. Gap analysis helps identify discrepancies between current performance and desired goals and is typically done via discussion or process mapping. whereas root cause analysis determines the details that contribute to the problem. When doing your analysis, it's important to focus on the symptoms to the problem, not the solutions or the evidence-based interventions to fix them. RCA is based on the basic idea that effective management requires more than merely putting out fires for problems that develop, but finding ways to prevent them. The primary goal of using RCA is to analyze problems or events to identify what happened, how it happened, why it happened, so that actions for preventing reoccurrence can be developed. Most RCA experts believe that achievement of total prevention by a single intervention is not always possible, and see RCA as an ongoing process that strives for continuous improvement. In summary, while gap analysis tells us what gaps exist, root cause analysis helps us understand why those gaps are present, and together they provide a comprehensive framework for improving our process. So before we talk about 2 RCA tools we frequently use with partners, we want to hear from you once again. Please share in the chat from the tools listed on this slide which root cause analysis methods are brand new to you or that you still may have questions about. All right, if somebody wants to read the chat, or we'll notate those and make sure that we capture that information from you. Thank you. Okay, so one tool our partners use is the cause and effect diagram, commonly known as the fishbone. A lot of times people don't initially like the fishbone, but it is personally one of my favorite tools. It's not just a visual tool, it facilitates structured brainstorming and promotes a thorough investigation of issues. It helps us systematically identify and categorize potential causes, leading to actionable insights. When putting together a fishbone, first ask yourself, why do you think this problem is happening? The question opens the door to understand the various contributing factors. Next, think about what else might be contributing to the issue. This is encouraging a broader exploration, ensuring we don't overlook any critical factors. Also reflect on the categories that might be missing from our analysis. This step is crucial as it promotes a comprehensive view of the problem, leading us to more effective solutions. And then finally, consider how long this problem has existed and its impact. Understanding the duration and effects can guide us in prioritizing our actions. So a pro tip, for this exercise to be effective and most helpful, the whole team needs to be present to gather all the diverse input from across the organization. Example, I had a partner working on colonoscopy referrals, but the referral coordinator was not in the room. So the meeting was not very effective and we had to redo it. It just simply didn't work without her input. Another tool commonly used is the 5 whys analysis. This technique encourages to repeatedly ask why. Think of a 3-year-old or a 4-year-old. This method helps us to uncover the underlying reasons for a problem, not just the symptoms. It's incredibly straightforward, and it doesn't require complex tools, which makes it a go-to method for many opportunities. Next, let's highlight its focus on solutions. By addressing the root cause, we can implement effective resolutions which truly make a difference. Additionally, this technique promotes a deeper analysis of issues, encouraging a thorough investigation that often reveals insights we might otherwise overlook. A pro example, when working on the same colonoscopy project and the referral issue, we determined quickly by using the 5 whys that the patients did not have the name or the number of the endoscopy center, therefore they didn't answer the phone when the scheduler was calling to make their appointment for their no cost to them colonoscopy. They attempted twice and then moved on. So it really just put a screeching halt to the entire project. So we determined that if we gave the patient or the caregiver the name of the center and the number to be expecting a call from, they felt more comfortable answering the call. And it was truly a wonderful process improvement that then was replicated across the organization for all specialty care referrals. All right. So many of our partners during the root cause analysis identify provider recommendation and staff education as potential symptoms to why their vaccination rates are low. But before embarking on implementing staff education as an evidence-based intervention, it's important to survey staff to find out, is there really a gap in knowledge and where does it lie, so that you can tailor your education to meet those gaps. Physicians and staff surveys not only assess knowledge on the topic at hand, but also can pinpoint if there's certain attitudes and beliefs, which is important when thinking about hesitancy and mistrust in the vaccination space. So while working on an HPV vaccination project, we identified that the medical assistant, who also served as the Spanish interpreter, was telling guardians that they needed the Tdap vaccine mandated for 7th grade in my state of South Carolina, and the others were not necessary, and that she actually had not gotten her own children the other 2 adolescent vaccines. She didn't understand the purpose of the other 2 vaccines, therefore didn't promote them. And therefore, our Hispanic children had an extremely low rate. So once we identified that and educated within the practice, we saw a tremendous increase. And we were able to convince her that it was important for her to vaccine her own children. So by administering a staff survey and pinpointing opportunities with knowledge, you can tailor train to areas where staff really need assistance to hopefully see improvement in vaccination uptake, and recommendations. Additionally, regularly administering surveys can help you monitor and sustain interventions and policy implementation. Now we want to hear from you again. Have you administered or planned a survey of physicians and or staff to assess knowledge, attitudes, or practices related to HPV vaccination? All right, since we're running close on time, we'll go ahead and end that poll and show not yet. So we've got some work to do there. So our key takeaways is that this was a fast and furious overview of capacity building stage of quality improvement. Here are the key takeaways. Gathering data is crucial in telling us a story, where we currently are and where we're going. It's crucial to recruit a robust quality improvement team. Process maps not only allow us to show workflows, but they help identify redundancies and can also be used as a training tool. And lastly, knowing your gaps and root causes can help you choose the best interventions that are going to allow you to have the most positive impact on your HPV vaccination rates.
Great. Thank you, Kim. Let me just add this. And we don't actually have time for Q&A, but I would love to do a huge thank you to Kim, Emily, and Jen. And if you guys could peruse the chat, I empower you to answer anything in there, and anyone on the call, feel free to put those into chat as well. And we can try to get you answers for that. I'm going to wrap us up today. I'm Christina Turpin, Director for the ACS National HPV Vaccination Roundtable. And I'm going to do a quick wrap up here, but all of the slides and this video will be on this as well. I'd like to launch the post-session poll for you guys. And while this is up, I'm going to keep rolling on through for you guys. So as you've heard, if you've been on past calls, we do have a landing page for all of the information that you've heard. On this landing page, you will find the slides, the recordings, as well as more information, registration form if you want to share it with colleagues. All of that can be found on this page and should be added into chat. We also have a really awesome resource roundup for you. And this, you can find all those resources that Kim talked about and all of the resources we've collected throughout, including some from Dr. Semprini from one of our first sessions. All of that is here in the resource roundup for you as well on that landing page. We have many quality improvement resources. So during those polls, some of you said not yet, we're working on it. You can find all of those things to help you through that process in our resource roundup as well as on the website. And I believe there's going to be links added to the chat as well. So moving into our June session, you can visit our 2024 recordings for a deep recap into all the QI work that you might be wanting to do within your clinic. And then next week, we're going to be viewing evidence-based approaches to HPV vaccinations, interventions, PDSA cycles, and sustainability. And I also wanted to highlight this awesome program that ECS has recently released called Cancer Risk 360. I believe that assessment link will be put in there, but it is a link that can help you assess your risk factors for cancer. Some things you can change, as well as lifestyle behaviors and choices, while others can't be controlled or modified, as well as age, family history. So all of that you can see in an assessment to help you look at your risk for cancer through the Cancer Risk 360. And that is the end for today. I want to thank Jen and Kim and Emily and Ashley, of course. And thank you to all of you for taking an hour out of your day and joining us. And we hope to see you next month. Thank you.